on this episode of A Tale of Two Hygienists.
The one thing about mobile sedation services in a dental office is a what I consider a Wild West. The rules and regulations for this is, even for states, is a very bare minimum, in my humble opinion. And on top of that, the quality of the people that are going into mobile sedation services is highly varied. Okay, so it's not like everybody has the same. There's no standardization for who can do anesthesia in a dental or oral surgery office. As a parent, I want you to know who's going to be taking care of your child. I want you to know what is involved, and I want to make sure all your questions get answered. Yes, I'm not going to necessarily take your anxiety all away. I think that's a natural experience and natural feeling to have. I would have it, no matter how experienced the person is. But at least we have this conversation so you feel more confident that when it goes down, when things are happening, that the best team is taking care of you.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.
Welcome back, everyone, to another episode of A Tale of Two Hygienists podcast, episode number 487. I'm your host, Andrew Johnston, and thank you so much for spending time with us yet again today. You won't regret it because this is a fascinating episode about sedation featuring Dr. Richard Marn. And while there are so many great parts to this episode, Jackie and I both, I think, came away with a similar feeling. And it was just blown away by the number of resources that Dr. Marn and his team have for us that are available for us to use. And one of those items, very specifically, was a medical emergency preparedness scorecard. I highlight this because I would love all of you to utilize it. We talked about it very briefly at the end of the episode, but I think this is something that you could use it during your monthly meetings. If you have monthly meetings, you could use it during a morning huddle and have discussions around it. And you can kind of just gauge the knowledge and the preparedness of each team member. And it's not just for clinical, it's also for front office. It's also not really intended, and I think that Dr. Marn mentioned something along these lines, but it's not really intended to see, okay, look, you're the smart one, you're the not smart one, but it really is to gauge people's strengths. And in an emergency, for me at least, I would want to know who my go-to people are for very specific things. Like, where are their strengths? I'm going to call on that person during an emergency. And so using this scorecard will help identify those individuals and their strengths and things like that. So in the show notes, I know I talk about show notes a lot. I think it's really important that you all know how to find these things. There are a ton of links in the show notes. Depending on what app you use, sometimes you just click on the title and that'll come up. Sometimes you have to click on into the episode body, it'll come up. But using the show notes for this episode is going to be super important. Additionally, we plan to have Dr. Marn on again. So if you have a specific question for him, or maybe even a topic that you want us to cover, please shoot us an email, andrew@ataleoftwohygienists.com. We'll be sure to get it on the show. And that's it for us. So with that, let's get into the interview with Dr. Marn.
A tale of two hygienists.
Welcome in, everyone, to another interview portion of the podcast, joined today by Dr. Marn and Jackie. Thanks for being here, both of you.
Glad to be here. Thank you for being here, Dr. Richard.
Thanks for having me, Miss Sanders and Mr. Johnston.
If we can splice in our intro a little bit of like the whole naming conventional thing, that'll clue the listeners in a little bit. We're not going to, don't worry. But Dr. Marn, here we go. So we have a lot to talk to you about today. I have lots of questions. Jackie and I were on ahead of time, just like trying to think about all the different things that could help, like the clinical hygienist in their role. One, understanding, like, if we're referring patients out, what should they expect? If we're talking to parents, what should they expect? There's so many things I think that we need to know as dental hygienists, even if it's not us actually performing the procedures. And so sedation is going to be the bigger topic, but could you get us maybe rolling into that topic by talking about your background?
Oh, certainly, sure. I'm Richard Marn. I'm a physician. More specifically, I'm a pediatric anesthesiologist, and I specialize in building safety systems that protect lives and dental and oral surgery practices. More specifically, the way we deliver that is through two basic ways. One is through our clinical work, which is mainly through our mobile sedation service that specializes in dental and oral surgery sedation, especially for kids. in dental offices and oral surgery offices. And the second way is through our risk management company that I co-founded with my wife, who's a pediatric dentist, and it specializes in reducing risk for sedation emergencies in dental and oral surgery practices. And so it's mainly through training, through some consultations, through some assessments, and of course, creating habits so that organization can be prepared for really any emergency should it come their way.
This is sorry to digress already, but, like, it's so fascinating that the 2 of you found each other, dentist and then medical. It's like, we talk about the medical dental collaboration all of the time. Did you
Oh yeah.
know each other ahead of time, like, before you did your schooling, or is this something you met later on and like, "Hey, you know what? We should do this practice together."
No, not at all. Um, the quick background is my wife, we met when I was a resident at NYU, New York University, and I was doing my residency. She was doing her residency, or I should say, she was doing some kind of, I think, internship. And through a friend, we connected. We apparently liked each other and fell in love.
Uh,
And then after we finished our training, we soon got married. Actually, during our training, we got married, and then we started working. And that's we just kind of met through a friend. It was just happened that this is what it is. Her friend, I'm sorry, her friend was doing her anesthesiology rotation at NYU, and she says, "Hey, I want you to meet a friend of mine." And so that's how we met, is through her friend who was also a dentist. So after we started dating and eventually got married, just so happened my wife got into a pediatric dental residency, and then of course I got into my pediatric anesthesiology fellowship. We had that was not planned. That was just something that we wanted to do. And then I ended up working, and then we started working. She went in private practice, and I started working at Mount Sinai Hospital, doing classic medical, pediatric medical, and adult medical anesthesia. So, liver transplants and tonsils and adenoids and hernias and some craniotomies and some real sick kids and some really healthy kids. And then after a few years, my wife and we started talking about doing sedation in her office because we were doing sedation cases, or I should say, full mouth rehabilitation cases in the hospital at Mount Sinai Hospital on occasion with each other. And I start to learn about the dental world, and we talk about it, of course, when we got home. And we started talking about, why don't we do this in our office? And so I started learning how to do sedation in our office because a typical medical anesthesiologist will not know how to do sedation in a dental office. It's a totally different arena in
Is
terms
this like
of
equipment or like what
its
is the big
equipment.
difference there?
It's equipment. It's about the logistics. It's about communication. And a big aspect is mindset. The mindset of a typical medical or physician anesthesiologist coming out of the hospital or even private practice is when you're in an office, part of it is you're by yourself. There's no other anesthesiologist around during a sedation in a dental office. You might have some support there, paramedics, nurses, medical assistants, but that is kind of Wild West. That's up to the decision of the practice and also the anesthesiology team that you hire, whether they actually bring those additional individuals to help the anesthesiologist and support them. But in a hospital, as you know, you have a surgeon, you have maybe an anesthesiologist around the corner. If you're connected with an ER, you have an ER physician nearby. You have anesthesiology assistants, anesthesiology techs, residents if you're in academics here. So there's a huge support around that anesthesiologist when you're doing these dental cases. Again, in the dental office, you have to build that. You have to build those systems. You have to build that team so that's aligned to keep your dental practice safe.
Do you practice in one state particularly, or do you practice in multiple states?
So right now, I practice in New York and on occasion New Jersey.
And the reason why I ask this is I know, in dentistry, it's a little bit weird. Medicine's probably also a little bit weird too, as far as like jurisdictions of what you can
Yeah.
do with your scope of practice, state to state, et cetera. Now, if an anesthesiologist comes, we'll say New York, we'll just say there, what is the requirements for other team members that have to be on there? Because I know in some states that you have to have a specially trained, some sort of an assistant to help like be on and monitor and do all of those things as well. Is that kind of across the board the same? What does that look like?
There is no law that says that the anesthesiologist working in a dental or oral surgery office needs an assistant.
Mm.
There's none.
In any state.
There in any, as
In
far as
any
I know,
state.
in any state.
Okay.
The recommendations are that if you're going to do sedation, let's just take a standard anxious adult case, right? Not take the pediatric aspect out of it. And you're doing an adult sedation. There must be two people that are CPR and ALS certified. And that's a recommendation that came out a few years ago. Again, is it law? Not that I know of. It's highly suggested. Now, that's with an anesthesiologist in a dental office. The rules may be different though if the dentist is doing sedation on their own. Okay.
Okay.
So that's a
Yeah.
different, slightly different animal where, and it could be state by state, where they not only require that the dentist have BLS certification, and of course ACLS if they are taking care of an adult, but there may be also requirements for an assistant that have at least a BLS certification. So I don't
Mhm.
know what that is per state, honestly,
Sure.
but that is something to look into. But yes, the dentist definitely needs to have at least BLS and ALS certification, ACLS
That's
certification.
fascinating. Yeah. So let's dive in a little bit more to like I think the dental office setting of
Mm,
this, and it's okay if your comfort level is staying with pediatrics, but I would like to know more about kind of equipment setup, the logistics, what needs to be on, I guess, on hand during the time, and then maybe after that we can go into like let's talk procedurally, like what happens first, what does the consult look like, what does all that stuff happen?
got it. Well, I can tell you what I do, and I can tell you a little bit about when in anesthesiology, or let me put it this way: if a mobile sedation service comes into your office and you happen to be there, or maybe even working with the anesthesiologist should bring a host of things, and I call it the MESV. That's my little acronym I make. MES-V. MESV. So what does that stand for? It means medications, equipment, supplies, and visual aids. So there's a whole bunch of things that you could list in any of those four aspects. But to simply put it, medications is not only do they have the sedation meds, but do they have the emergency meds? Okay. Um, not and beyond just what a typical dental office would have, right? A typical dental office will have the albuterol, some Benadryl, some epi, but the anesthesiologist should have naloxone, flumazenil, these reversal drugs, and other emergency drugs like amiodarone and adenosine, a full-on code. So in other words, do you have the medications to run a full code if you need to, right? That's medications. Equipment is, do they have standard monitors? So, blood pressure and, pulse oximeter, but also do they have end-tidal CO2? You'd be surprised. There are some, some, I'm putting this in quotation marks, mobile sedation services, or an anesthesiologist or a dentist anesthesiologist or somebody that does sedation that will not bring an end-tidal CO2. They'll bring a pulse oximeter, blood pressure cuff, a basic monitor, but it doesn't necessarily have end-tidal CO2. That's only what I've heard out there in the community. So do they have those standards, right? That's equipment. And not only just monitoring equipment, but do you have an ambu bag and a mask? And again, do you have the tools to manage a kid of various ages, as well as the masks, the ambu bag, suctioning? What if the power goes out? Do they have suction? Manual suction. So those are some of the equipment aspects. Supplies include nasal cannula, endotracheal tubes, LMAs, oral airways, things that a typical anesthesiologist should carry anyway if they're going to give sedation. And then finally, visual aids, what sometimes we call in the simulation world, cognitive aids. And all that is a uh, is a document, or sometimes it's an app that can you help guide you during an emergency, because your recollection and memory during a critical event sometimes will wane or dissipate because not everybody can remember anything. So if you imagine, if the patient's oxygen level is 50%, the heart rate's 40, the blood pressure is barely palpable, people just can't remember what that epinephrine dosage is, or
Mm.
or the atropine dose, or the dose for maybe a paralytic or what have you, because they become so emotionally flooded during a crisis that they cannot sometimes remember even their phone number. And that's what
Mm.
one of my mentors to say, when emotions go up, intelligence goes down. And when someone's life almost is in your hands, even for anesthesiologists, for ER docs, EMTs, paramedics, sometimes that emotion is so flooding that you can't remember basic things that you would think you would otherwise know. And so that's what the visual aids do. It's a visual tool to help guide you when to help guide your intellectual decision making. So
That makes
that's
sense.
some of the what I call MESV.
I'm actually really curious about if there's a percentage of like dental practices, especially pediatric practices, that would maybe get self certified, I guess, to do anesthesia versus bring in a mobile team like what you're talking about now. And
Mm.
then also, obviously, when a mobile team comes in, they have all of these things. Is that more beneficial than saying having the practice provide all of these things and you just come in, or does that never even happen
Ah.
that way?
So what you're saying is have the practice invest in those tools, the
Mhm.
MESV,
Uh-huh.
equipment, medications, equipment, supplies, and visual aids, versus the anesthesiology team, and just basically hire a body for hire, if you will, gun
Yeah,
for hire.
basically. Basically.
Yeah, but do you
Um,
want to depend on that? As you said, some offices don't
Huh.
even have the basics. So do you want to, as a hired body, do you want to go into an office that
yeah.
says they have that stuff and then you find out, oops, no, they don't?
It's
So
expired or whatever.
well, there's true. There's a lot of different ways to skin the cat. The one thing about mobile sedation services in a dental office is a what I consider a wild west. The rules and regulations. First of all, it's not. The rules and regulations for this even for states is very minimal. It's a very bare minimal, in my humble opinion. And on top of that, the quality of the people that are going into mobile sedation services is highly varied. Okay, so it's not like everybody has the same. There's no standardization for who can do anesthesia in a dental or oral surgery office. So, and by the way, to you kind of alluded that they should bring this equipment. Like I alluded to that other case where there was this anesthesiologist that was bringing basically a toolbox. That's all they bring in. They didn't bring anything else except a toolbox. So there's a lot of assumptions that people make about what the anesthesiologist should bring, and quite frankly, you have to vet your anesthesiology team, no matter if they bring their own stuff or not, whether they're even bringing the right tools and equipment, what if they're even qualified appropriately? Do they have the right expertise? Okay, so I think we're opening a big bag of options here. Um, so let me see how I can address this.
Let me ask you this. If, unfortunately, if something does go wrong, is it joint fault, the anesthesiologist and the dentist?
I think it depends. I mean, obviously, that's more of a legal
Okay.
question.
Yeah.
I think obviously with an anesthesiologist there, it helps offset some of the accountability and the risk should something go down. And obviously, if it's all sedation related, you can, obviously fingers get pointed to the anesthesiology team since that's often it's a variable that increases the risk for problems during sedation. I think that's more of a question for the lawyers. Like, say, if you bring anesthesiologists, who's statistically more likely to run into problems and take more of the accountability? I think it depends. Like, what, for example, what if you're doing a sedation case, and the dentist dropped a crown and it gets aspirated while the kid or adult is being sedated? Now, is that, yes, the anesthesiologist sedating the child, but at the same time, the dentist lost control of of
The
the
crown.
um the crown.
Yeah.
And then so there's a lot of rabbit holes you
So
can go
there's
down.
joint vetting. It goes both ways.
Yes. The point is in a lawsuit, it's going to be a headache. It's a big headache. It's a big stress. It's a huge liability for everybody involved. The way I look at it is sedation is not for the faint of heart. It is a high risk event, honestly, in an office that is less prepared for those type of events unless you prepare that office for it. Okay, you have
Mhm.
like I talked
Yep.
we talked about at the beginning. There's less capacity, there's less staff around, for example.
If there is, this is if it's high risk, but obviously maybe high reward, is Is there a huge financial upside for an office to bring in a team like
A good
this?
question. All right.
Yeah.
So, I've had conversations with my clients about this, both pediatric dentists and oral surgeons. At first, from a financial standpoint, a, mo- a mobile sedation service doesn't necessarily make you more money. It depends on how it's structured, right? So I used to do cases in Ohio. We used to do a lot of open airway cases, and would the dentist would charge an additional fee for the day to that patient, besides the dental fee.
Mhm.
Okay, so there were three fees involved. There was the anesthesiologist fee, the dentistry fee, and then also a fee that the dentist charged that went to the office, if you will. Okay.
So, like, for, like, the convenience of having it in the office kind of a fee?
Yes,
Yeah.
they
Not
had
really
some
associated with
wording.
procedures. Okay.
Yeah, but we're bringing the staff in and we're closing office for you to do the sedation, and so there's a way they justified it,
Sure.
but that's how they made a little extra money
Mhm.
because doing the dentistry wasn't going to necessarily make you more money whether you do it under sedation or awake.
Sure,
So
sure. Okay.
that's how they made a little bit extra money. Now, but in general, most mobile sedation services are not going to make you money initially. I don't think that. I don't think it does. What it and I would say talking even with oral surgeons, it doesn't necessarily make you more money because one, it takes away the money that they would otherwise charge for the sedation service that the anesthesiologist is now getting paid for.
Mhm.
But furthermore, and then having an anesthesiologist there takes time. Remember, you have to now have two rooms. If you have multiple cases, you're doing one case in one room. You finish that case, you transport that child to another room so they recover, usually another chair. So now that chair is taken up, unless they have a little area that they don't use for cases. But still, you have staff, and then you have to now start the second case in that room. So it does take up resources, and so financially, if anything, it breaks even. It's not you're not going to necessarily make huge money, in my opinion, on this if you bring in a mobile anesthesiologist. But the long-term benefit is that you become now a referral source. If you become known
Mm.
in your community as a high-end, high quality, very, very, very safe sedation service for your community, other offices that don't want to do sedation will channel those patients to you. And now those patients, well, most likely they may you don't want to steal the patient from your referrals, but they may either go back to that patient or they may come back to bring their family for other work. For example,
Mhm.
I I do sedation for an oral surgeon. She does not want to take care of kids. She's happy to have me come in as a pediatric anesthesiologist. Does not want that stress.
Yeah.
And so what she does is I say, does this make you money just me having come? Says, well, what it does, it helps keep our patients in our practice, but also because they're being referred from another pediatric dentist or a general dentist, what happens is that family now sees the work I do for the kid that you just sedated, Richard. And now they're going to say, oh, well, my kid later on in a few years needs their wisdom tooth extracted. Or maybe my husband needs an implant. Or maybe now I need work done, maybe for an abscess. I remember, that oral surgeon that worked with Dr. Marn, they did a great job. I'm going to go to her. And so it kind of potentially grows your patient base by having a specialized sedation service that does not initially make money at the start.
Yeah. No, that makes a lot of sense. I was thinking, and I came back, and I backed off this question earlier because I was thinking about the consult, and I was just thinking, you mentioned you have 2 chairs. Do you actually do consults, or what's the handoff between the, the dentist and the anesthesiologist at this point?
So I can't speak for everybody else, but what we do is the dentist office simply reaches out to our team, and once we get word of this team, we basically reach out to the parents. We introduce ourselves. We kind of present a little bit of a introduction either through video and or personalized phone call. Provide the information. The parents always want to know two bits of information. Number one, do they take insurance, and how much does he cost? That's what and that's what parents always want to ask, and understandably so,
Yeah.
because nobody goes to dental office or surgery office thinking, oh, I need to get I need to get an anesthesiologist.
Right.
And so we become basically the partner to that oral surgeon or dentist, and make sure that they're the right fit for our care. So just because they get referred to me for their care doesn't mean that I should take care of them. So sometimes oral surgeons or dentists will say, listen, we have this case. I'm not sure about their medical history. I need you to check it out. So I will vet those patients out. So after they reach out to us through my assistant, say Deidre, she's my assistant, she will then collect information from the parents. The parents send their intake form to me. Basically, I review it, give the parents a call a few days before the procedure, if not maybe sooner if there's any red flags, and we go over it carefully. We basically do three things in that conversation: review the health history, talk about the anesthesia plan, answer any questions. It's a great opportunity for the parents to get to know me days before the procedure. I mean, how often is it that they talk to an anesthesiologist that far in advance?
Yeah.
We also have a pediatric anesthesiologist personal number in their back pocket. And it just gives them an opportunity in that phone call, what we call our care call with me, Dr. Marn, to just talk and just kind of vet out and share their anxiety and stress that they have, because almost invariably, almost all parents, not everyone, but a lot of them have a lot of stress and anxiety leading up to the sedation date. And so I love talking to these parents days in advance, because just talking with me and knowing what's going to happen and getting all their questions answered makes these parents so much more appreciative that I'm going to take care of them, and there's a plan and there's a person to this. Unfortunately, there's other services that a nurse interviews them, and then when they come on the day of the procedure, they are just getting to meet their anesthesiologist, and it's not as personable. And I try to design this care, our experience, as if my own family is going through it. So that's why it's very much high touch and high experience.
Well, it's part of a practice builder. I mean, for me as a dentist, if I'm an owner, it's like I'm gonna want someone that's gonna be more invested than, yeah, day of appointment. Like, hey, how's it going? I'm gonna go ahead and put this kid to sleep. It's
Yeah,
like,
Well,
I
hey,
totally agree.
as a parent or a mother who's normally not having a child sedated for any type of dental work, they're scared to death. So knowing that you have the expertise that you do, is calming to a parent, for sure.
And I tell parents, I say, listen, you may not know me, but I want you to Google me. I want you to Google the heck
I
out of
did.
me. Uh, I hope so. Thank you. Yeah, I'm glad I'm not Steve or John, right?
No,
You got the
no,
wrong person,
no,
the
no,
right
I got the
person.
right one.
But I tell parents, I say, listen, I want you to feel confident. This is what I do is unique. It's not every day that you're going to get your kid sedated, let alone in a office. And you, as a parent, I want you to know who's going to be taking care of your child. I want you to know what is involved, and I want to make sure all your questions get answered. Yes, I'm not going to necessarily take your anxiety all away. I think that's a natural experience and natural feeling to have. I would have it, no matter how experienced the person is. But at least we have this conversation, so you feel more confident that when it goes down, when things are happening, that the best team is taking care of you. And even that conversation, I will build up my clients, because I want to work with the best. And so I want to make sure the parents know that it's not just me. It's about how we build our team for success on the day of that sedation. It doesn't take much for that sedation to go backwards and to go downhill in a very negative way with bad outcome. I like to make sure that the team that I'm with, the dentist, the dental assistant, the hygienist, the front office people, are on the same page. I'm a big believer that team alignment that has been stress tested is how you'll keep that child safe, or even adult safe, in a sedation office. Because that's literally how the best teams do it. You look at Navy SEALs, the best commercial airline pilots, the nuclear power. I look at a lot of different safety industries. When you look at how these teams perform, they're constantly testing their alignment to making sure they're ready for that event. And so I just want to bring that into my own care when caring for these parents. I mean, these patients. And I share this with parents. I'm very transparent about things. I'm saying, listen, if I don't think I can take care of your child, I will let you know, and I'll tell you why. So I would, in that conversation, I'm going back a bit. In that care call with Dr. Marn, I tell them, sometimes I say, you're not the right patient. Either you're too young, you have these issues that need to be addressed first and be optimized. Maybe you have some underlying family history that I'm concerned about, and I don't want to deal with that risk should your child have that. And I'll express that to the dentist because what's ultimately for the dentist, my goal is to protect their practice. Yes, I do that in protecting the child, but ultimately my goal is to protect that dental practice and their reputation. And to do that, I got to protect that child and present a very professional, high safety, high quality team and experience for the parents, the child, and also the dental team.
I love it.
I've got a question. So after the procedure is finished and the child is done, what does the recovery process look like and who is with the child at that time?
Got it. So the way I do it, and I can't speak for every other people, but I I either recover the child myself
Okay.
or have a paramedic or nurse come in and do the recovery with me.
Okay.
Okay, because that's kind of standard of care, if you will. I know of other people that will have a medical assistant
Mhm.
or maybe will train the dental team to do the recovery.
Mhm.
Um, I don't think that's ideal. So what I'll do is I'll recover them myself. And in that recovery, I tell the parents, I tell the nurses, and I tell the paramedic that I hire, listen, we have to for the kid to go, you have to do three things. You have to say their name, you have to touch your nose, you have to stand up on your own. If you can do those three things, you can get out of here. And so people say, well, why does that matter? So okay, I'll tell you why. Number one, if you have to see your name, I want to make sure that your larynx, your vocalization, your reflexes are intact. Okay, because my anesthesia may have suppressed it. I want to make sure it came back. Number two, I want you to touch your nose. I want to make sure that you can follow commands, but also that you have fine motor and proprioception is back as well. And number three is I want to make sure you stand. You don't have to walk. We'll put you in a wheelchair, or if you're a child, we'll carry you home. But number three, I want to make sure that you have your gross motor strength back. Sometimes we get these kids, they meet the first two criteria, but then when we ask them to stand, they got like Gumby legs. Like, okay, you're staying a little bit longer. I want to make sure you're a little bit stronger. So
I love
that's
it.
what
Well,
we look for in a very small nutshell.
on any given day, Jackie can only pass 2 of those 3 anyways, so it's
Yeah,
like,
that's
it's too
right.
bad.
That's right. It's
Um, I
I'm
know
not
Jackie's
gonna
like,
ask
trying to touch her
which of the
nose over
three.
here.
I'm not gonna.
and they can be in any order, right?
Yeah, it doesn't matter. I
It
just
doesn't
roll the dice
matter.
on one of these days. Hey, so doctor, I sorry to monopolize your time. Hopefully you have a couple more minutes. I wanna end on this kind of the final question of kind of adverse events and just kind of preparing for that, because I think one of the
Mm,
things that happens, especially with dental hygienists, is and this happens on the dental side probably more than the sedation side, but it's, you go see your hygienist, and then the doctor comes in, doctor says, hey, you have all this restorative needs that need to happen. And then they turn back to the hygienist. They say, oh my gosh, you're my best friend because I spend all my time with you on all our appointments. What did they really mean? Or what can I expect? Or what is this? And so I know we don't have time to go over like every medical emergency that happens, but like what is maybe like the top one? And then like how do you manage that event?
okay. So there's that's a few things there. Let's talk about what's the most likely medical emergency. So when you look at the statistics, most likely medical emergency is syncope. Someone gets lightheaded and kind of passes out, and or anxiety, right? They're super anxious and they can't sit still. But usually those are not very high risk.
And but
Um,
in sedation, you kind of want that, right? You want them to go to sleep, right? Like, I
Pass
mean,
out.
you're doing half your job for you.
but are you talking about like medical emergencies without sedation?
Wait, no, specifically for what you would encounter as
Oh,
the
I see.
anesthesiologist.
Okay, I'm sorry. I thought you said medical emergencies in
Oh,
general for any dental office. Okay. Sorry, misunderstood.
Goes with the Gumby legs.
Yeah. All right. So the most likely issue with medical emergency in a sedation is most likely apnea or hypoxia. So someone's oxygen level goes down. It could be a bunch of different reasons. Could be laryngospasm, bronchospasm. It could be aspiration. It could be hypopnea, okay, or apnea. The breathing slows down or stops. So those probably the most likely emergency to occur during sedation. And the other question you asked was,
How would you manage that?
how you manage that? Okay. So most emergencies I'll say the majority of emergencies are almost always in sedation, are almost always hypoxia related. Their oxygen goes down for whatever reason. The question is, can you and your team recover from that? That to me is the crux of how aggressive or whether you can do sedation or not. Because if you know how to rescue somebody from hypoxia, the majority of your sedations can be very, very safe. That's a big issue. So the problem is when dentists and oral surgeons, honestly, because they don't have that much experience with airway management, like a typical anesthesiologist would, is that rescuing a patient when they're hypoxic requires a unique set of skills. But sometimes some of the most basic ones are overlooked. And so if you know how to do a mask ventilation effectively, I believe you can save 95% of all sedation emergencies if you know how to mask ventilate appropriately. A lot of people don't know how to do that well. And the only way you can do that well is practice, getting feedback and practice again. That's the only way you can get at, like anything that's a skill. There's a lot of other things to do that are important as well, but as a individual skill, that will save you from, if you know how to mask ventilate, that saves you from needing to put an oral airway in, a nasal airway, an LMA, an intubation. It saves you having to do a cricothyrotomy if you know how to mask ventilate a patient effectively. A lot of people panic and they start thinking about more aggressive airway techniques that may be unnecessary and may be premature. And so to me, having done a lot of sedations, especially on kids who decompensate quickly, knowing how to bring that, rescue them from that hypoxia is very, very critical.
Wow, that's good. Doctor, I mean, I have so many more questions and hopefully you'll be a guest on again. If there are team members and or dentists that are listening to this that want to know more about you or they want to find out what services you provide, how can they find you?
I think a great way is LinkedIn. I'm the only Richard Marn on LinkedIn. You can DM me. That's one option. The other option I highly recommend is, especially if you're a dentist or hygienist or even a practice manager, consider taking a scorecard that I have. I have an online scorecard. It's at emergency.scoreapp.com, or it's on my website as well. And what it is it allows you to assess your medical emergency readiness for your dental office. So if you're like, how prepared am I for a medical emergency? This allows you to kind of go through these steps and questions. It takes about 5-8 minutes to go through and assess, either for yourself or also for your team, if you're actually prepared for a medical emergency. It looks at the gaps or strengths. And it's very professional looking. We send you a PDF document that you can actually print out that gives you a score, breaks it down into different categories, and shows you where you can improve upon, and also suggestions on how you could make those improvements. So I can show you that link later on if you want.
Yeah, no, I'll put that in the show notes. No,
put it in the show notes.
This is
that's something we need
hygienists.
to
Listen,
include.
this is something hygienists. I think that you could take this to your morning huddle, whether you do it, beforehand, and everyone just brings their PDF, and you guys talk about where y'all at as an office, or do it real time at the office as a part of your morning huddle. I think it's a great idea. Dr. Marn, thank you so much for being here. Really appreciate it.
My
Thank you,
pleasure,
Dr. Marn.
Mr. Johnston, Ms. Sanders. Thank you so much. It is my honor. Thank you very much.
It was a
I
fun
appreciate it.
time.
Awesome.
Thank you.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.